my name is Mark Belden. I'm here today to talk to you about the Region 3 MCI Plan Manual 2 control facilities. The Region 3 plan for control facility operations is designed to help the distribution of patients from a mass casualty incident to area receiving facilities. So first slide I want to show you is some MCIs, and what are we going to do? So the providers get there and get all the patients packaged up, and now what are they going to do? Well, what they're going to need to do is contact a control facility, and the control facility will help them distribute patients not only to local facilities but other facilities around the region. And it's more appropriate for the patients to at least get the care, even though there may be an extended transport time, they're getting more appropriate care. So some assumptions as we move forward through this training is that all field responders and those folks in the hospital have had at least ICS 100. We strongly recommend ICS 200 for greater knowledge of the incident command system, which is used in the field extensively. Also knowledge of FireScope, which is a method of operations or guides that we use in the field for firefighters and EMS personnel. Basic awareness training of the Region 3 MCI Plan Manual 1, which are the field operations for MCIs. And also an MCI basic operations class is strongly recommended. So the purpose is to outline a plan under the Standardized Emergency Management System, or SEMS, and the National Incident Management System, NIMS, for the distribution of patients during a multi or mass casualty incident within the operational area or county, or within the operational areas in the mutual aid region and destinations outside the mutual aid region. This slide here shows a little bit of what happens, or the flow of an MCI. You have your event, which is reported to the control facility by means of either saying an MCI Alert or confirming the MCI or canceling it. All those that should be going through the control facility. The control facility then contacts the acute care receiving facilities, as listed here in this flow chart. There's other notifications that are simultaneously going on, and that's through the MOOC, the RDMHS, EMSA, and disaster management systems. So as we go through this, what I'll be covering are the control facility operations, receiving facility operations, the operational area, what happens in your county or even the area around it during an MCI, and then also the disaster medical health coordinator specialist. There'll be a few things there at the end in the appendices. So pre-event responsibilities. The control facility shall be authorized within each operational area by the LIMSA for a purpose of coordinating patient dispersal during an MCI or other event requiring coordination of patient destinations within the EMS systems. Now, there are no control facilities within the NorCal region. However, agreements are in place for control facilities and other LIMSAs to cover NorCal counties. The control facility is responsible for staffing and having the available resources to handle a mass casualty incident. They also are required to have communications, and one of the primary ones of that is EM Systems, which is a web-based reporting system, which all hospitals in the Northern California regions have access to and monitor. Obviously, landline and two-way radio communications are important. You have to remember when in the NorCal EMS region, there are challenges with cellular data as well as two-way communications, and you may wind up using a combination of both to get the information you need from the scene to the control facility. There needs to be a liaison or coordination, a control facility supervisor within the local receiving facilities. This is really important to have one person that can assist with getting training going and maintaining that training throughout so that everybody becomes aware of the control facility. Again, there's no telling when these disasters or mass casualty incidents may occur. It could be between 8 and 5 days a week when the majority of the folks are in the hospital, or it could happen at 1 o'clock in the morning on a Sunday. Also, it's important to continue to have trainings, which include exercises and drills. And again, these should be done at various times throughout the day and through the week so that more folks become aware of the plan and can train and exercise with it. So creating an MCI event. This shall be done by the control facility when information is received from the scene regarding the potential to coordinate patients among multiple receiving facilities. Information may be from multiple sources. EMS personnel, that's the most likely. It's either going to be fire EMS personnel that get information that the scene may be an MCI, and each LIMSA is a little bit different on what they consider to be an MCI, so make sure you refer to your local LIMSA policies for the definition of an MCI. If there is a suspect, the field providers can contact the control facility and advise them that there's an MCI alert, and that puts the control facility on notice that they may be getting an influx of information and patients that need to be distributed around the region. When the EMS providers arrive on scene, they will either confirm or cancel the MCI. Dispatch agencies may also be proactive if they hear the information that's coming through, that if it's a bus crash or a train crash, something along those lines, they may go ahead and initiate an MCI alert as well. MCIs can be called by local government, other control facilities. If the incident is near the border of one control facility and it will be impacting receiving facilities in another control facility's area, they may be contacting them to assist them with distribution of patients. Also, the LIMSA or the MOAC may also create an MCI. When it's determined that an MCI event is necessary, the control facility shall assign appropriate staff to the MCI event. It's really dependent on the control facility to figure out how many folks they're going to need. They're definitely going to need to have, I strongly recommend at least 2, but they may need more depending on their staff, the size and scope of the incident. Creating the MCI event in the EM resource as quickly as possible will assist in notifying other providers around the area that there's an MCI. Multiple providers in the area have profiles set up on EM resource and receive those notifications for not only the real thing but for drills as well. Locate the event, the MCI, on a map so you can identify the receiving facilities that may be impacted by this event. Maintain communications with the medical group supervisor or communications coordinator at the scene. If additional receiving facilities are needed outside the operational area, the control facility shall contact their neighboring control facilities. So the receiving facility status reports, they complete when they get the alert from EM Resource that there's an MCI event, and they report how many immediate, delayed, and minor patients that they can handle. There are some criteria for each of these patients I'll get to here a little bit later on, but they load that into EM Resource so the control facility can see how many patients that receiving facility can take. That needs to be done within 5 minutes of the initial alert. Field Medical Communications Coordinator shall be referred to by the incident name and medical. For example, if the incident was on Sunrise Boulevard, it'd be Sunrise Medical. Those are typically called an incident or the Sunrise Incident, and then those positions within that ICS structure would assume that name of Sunrise and fill in the blank there. The control facility should be referred to by county name. For example, Shasta Control or Butte Control. All EMS radio traffic needing patient destinations shall be routed through the control facility, even for non-MCI patients. This is very important that we don't overstress any one receiving facility. So if the control facility doesn't know where the regular ambulance patients are going, ambulance X may be transporting to facility Y with a code blue that's going to take up several resources. If the control facility doesn't know that, and the receiving facility has reported that they can handle an immediate 2 delayed, they may be adversely impacted by that code. So it's important that the ground transport providers are notifying the control facility during the confirmed MCI of what they have and where they're requesting to transport to. During a declared MCI, patient reports shall not be given directly to the receiving facility by the transporting units from the MCI. The ground providers really need to have the time to take care of their patients because they're most likely going to have more than one in the back of their ambulance, and they need to focus on treating those patients. Also, we need to make sure that the radio frequencies aren't being tied up with patient reports, especially long drawn-out ones. The patient transportation group supervisor communications coordinator will relay to the control facility of the patient age, sex, and injury type, along with the last four digits of the triage tag number, so that they can record that information and relay it to the receiving facility, so they do have a heads up that they're receiving a patient or patients. The control facility shall update EM resource anytime new information is received from the field, including changes in total patient counts, triage categories, destinations, etc. So it's very imperative that the field continually communicate with the control facility for updates and status. That may be if there's an immediate that expires, or they get into another part of the scene and find additional patients. Typically, in a large scene where patients can be scattered, even minor patients or some what would normally be considered delayed patients become dazed and walk off, and those patients can be found later and adversely impact the incident. The control facility shall confirm the total number of transport resources available and begin the destination worksheet. So again, the control facility is communicating back with the scene to determine what type of resources they have, whether ground or air or other alternative transport resources like a bus that they have, so that they can help figure out where the patients are going to go and how they're going to get there. The control facility should be reassessing the receiving facility's capabilities regularly when transport or scene times are extended. Again, you never know what's going to walk in the front door of the emergency room that could impact that receiving facility's ability to receive more patients. When the control facility is notified by the medical group supervisor or the communications coordinator that triage is complete, the control facility shall document the patient information on the patient destination worksheet. It's really imperative that as the incident progresses, communications is continual between the field and the control facility, but also the documentation is there. Many of these scenes are going to be considered crime scenes, or may be considered crime scenes down the road, and documentation in every level is extremely important to help paint the picture of how the incident went and how patients were treated. When contacted by the field for patient destinations, the control facility shall assign destinations using their destination guidelines. The control facility shall notify the receiving facility of incoming patients using the patient dispersal form in EM resource. So some of the guidelines. So for immediate patients to facilities, you want the immediates to go to the closest appropriate facilities, hopefully within 30 minutes or 30 miles transport time from the incident whenever possible. We know that can be a challenge in the NorCal counties, but we just need to try and do the best that we can, whether we're using ground or air resources. Send immediate trauma patients to the nearest trauma centers when possible, following local EMS protocols. Send immediate pediatric patients to pediatric centers when possible. Now, this is important that if you're using air resources, it may not be appropriate for that air resource to transport the pediatric patient to the nearest facility, but consider using that air resource to send that pediatric patient to a more appropriate facility, even if it is a further distance out by air. Delayed patients, they can be sent to delayed or immediate teams within 60 minutes of transport time, whenever possible. And minor patients, they can go to pretty much any local ED, or they can be evaluated and re-triaged and receive additional care if necessary. And those minor patients may be transported by the alternate transport vehicle or a bus. When more patients exist than available teams to accept these patients, need to consider requesting local receiving facilities to increase patient capability, sending more patients to local teams rather than standard guidelines recommend, or sending patients beyond the standard transport radius. So you may need to send the patients further out. When it talks about talking to receiving facilities about increasing their patient capabilities or sending more than local standard guidelines recommend, that may just need to happen. For immediate patients, you're supposed to have a surgeon and a ER physician and a nurse for one immediate patient. You may need to alter those standards to be able to take care of those patients. So as the event hopefully begins to wind down and the event needs to be ended, it can be ended once all patients have been distributed. The control facility shall update the MCI Event and EM resource. All patients need to have a destination, and the scene needs to be aware of those destinations so that as patients are loaded into ambulance or alternate transport vehicles, they have a clear knowledge of where those patients are supposed to go. The control facility will provide a final summary of the event to participating receiving facilities, including patient destinations, and that would flow something like 1 immediate, 2 delays to St. Elizabeth's, 5 minors to Modoc Medical Center. Something like that will be loaded into EM resource and sent out to all those participating in the event. After providing a summary of the event, approximately 5 minutes, the control facility shall end the event and notify all participating facilities that the event has ended, that all patients have been given destinations. The receiving facilities may have not received all the patients yet, but they're being loaded and will be en route. Once the event has been completed, the control facility and all participating receiving facilities shall complete an MCI critique and file all MCI paperwork. It's also a good time for the control facility to meet, if possible, in person with the medical group supervisor or patient transportation group supervisor from the scene to review all the paperwork and review destinations for all those patients that were transported. The control facility supervisor shall coordinate an after-action review with the local EMS agency for any unusual event or MCIs with greater than 10 patients. MCIs are not the day-to-day activity. That's not something that we plan or hope to do on a day-to-day basis. So it's really important that with any declared MCI that there's follow-up afterwards of things that went well so that everyone knows and we want to continue doing those things that went well, and also to identify those things that could have gone better so that hopefully on the next one that they do go better. Know that in most MCIs, they may appear chaotic in the beginning, but at the end of the day, patients are getting taken care of, they're getting transported off the scene, but we really do need to focus on some things during an MCI. One of them is communications, because that is one of the main failure points in an MCI. But at the end of the day, things do go well, we get the job done, but there are always things that can be done better. Communications is the first one, and just minor things on the end of that. Providing the last 4 of a triage tank to the control facility will assist them in patient tracking down the road. So receiving facilities, your pre-event responsibilities. Receiving facilities are obviously authorized within the operational area by the NIMS for the purpose of receiving patients transported by ambulance. It's incumbent on those receiving facilities that they have the staff and resources necessary to take care of the day-to-day patient loads. It's hard, there's no way to plan for an MCI, but also have the capability of calling in staff off duty to backfill other staff as needed. Having the communications in place with the control facility, so having the web-based EM resource available at all times, having landline, having the numbers for the control facility handy, so if you need to contact them via phone or even if it's by radio, folks in the emergency room know how to do that. It is best to have a liaison that will coordinate and assist with training with the control facility. And again, training is paramount. Even just running through small drills, and really recommend using the small drills. That helps you prepare for the larger incidents. You don't need to not every one of your drills need to be a 30-patient bus accident or train crash or something like that. Even the 5 to 10 patient motor vehicle collisions can stress systems. So train with those first and then gradually increase. Facility status updates. I'm sure most of you know that are taking this training, if you're hospital-based, that you are required to update your hospital status in EM resource every 24 hours. This is really important that when folks log on to EM resource in an emergency, that they can look at your facility and see if you're having any challenges that day, whether you may not have neuro coverage or OB coverage or cardiac services, or your MRI or CT scanner may be down if you have those capabilities. But again, it needs to be updated every 24 hours. So somebody in your facility should be designated to do that. Really, it should be a charge nurse or somebody that's going to be there during that time, and that multiple people have access and knowledge of NIMS systems. EM Resource will automatically prompt each receiving facility to update their status at 8 a.m. You can see your EM Resource user guide for more information on that. So for receiving facility, responding to an MCI alert. Once the MCI alert has been received, facility personnel needed to determine what their capabilities are. How many patients can they receive? Verify that there's surgeon availability for immediate trauma patients. If there's not, you may not be able to take an immediate patient right away until a trauma surgeon becomes available, or you may be limited in just being able to take the delayed patients or minor patients. Enter the facility capability in EM Resource for immediate delayed and minor patients within 5 minutes of the request. It's paramount that if the early notifications are going out for the MCI alert that there's something big going on, that the receiving facilities in turn reply within 5 minutes of what their capabilities are going to be. And obviously you want to follow your internal hospital policies for this type of response and notify your charge nurse or nursing supervisor. Continually monitor the updates. As incidents progress, the control facility will be updating the status of the event and where patients are going. So it's very important that the receiving facilities continually monitor EM Resource. Keep the charge nurse and health supervisor updated as to the incident status, department staffing, and resource availability, or what more staffing that you need to manage the patients that are coming in. You'll be notified by the control facility of incoming patients. Print or document the patient information and assign treatment teams and prepare for the receiving of those patients. Notify trauma or surgical services regarding the ETA of incoming patients requiring the respective services. Hospital admitting personnel do play an important role in this because we really need to track the patient from the incident site through their admittance and care in the facilities, and that can be done by recording the triage tag number. The standard is recording the last four, but if they're able to put the entire triage tag number on the chart, that is also beneficial. It's really important to see how we're doing and how all the patients from an MCI turn out. So being able to track that through a triage tag number would be very helpful down the road. For receiving facilities, the have-been poll. I know some facilities don't think that this is an important task that they need to do, but it truly is. It's a way of practicing bed availability in the hospitals. The purpose of the Have Bed or Hospital Available Beds in Emergencies and Disasters program is to standardize real-time hospital bed and resource availability in a system that can be used by decision makers. So that's loading an EM Resource. So when the alert goes out on an EM Resource that there's a Have a Bed drill, you really need to get that information in within 30 minutes. Have bed drills may be generated locally by a control facility, the MOAC, or EMS agency to assist local resources, or may be generated by the RDMHC or S to assess resources throughout the region. Paramount through the flu season or any pandemic event, so they can get a visual on how facilities are being impacted. Each hospital charge nurse or designee will request the house or nursing supervisor to provide the availability of each of the Have a Bed categories using EM Resource within 30 minutes of their request. So EMS agencies shall be notified by the control facility for any events requiring receiving facilities beyond those currently listed in EM Resource. If a hospital events involving hospital evacuation, for our area, wildfires, that may be a cause for hospital evacuation or an internal disaster within the facility. Any event requiring crisis standards of care protocols, the inability of the control facility to conduct patient distribution activities. If the control facility is impacted by the incident, they may need to acquiesce their responsibilities to another control facility. Other criteria established by the EMS agency or the MOAC. Any EMS agency or MOAC may be activated by the RDMHC or S for receiving patients from an event outside the mutual aid region. For local events that exceed the capability of facilities within the mutual aid region, the EMS agency or MOAC shall contact the RDMHC or S to facilitate inter-region patient distribution and coordinate the transportation needs of field responders as necessary. So if you have a very large incident and you're having issues getting patients out of the immediate area, if they need to go to hospitals in other mutual aid regions, the RDMHS in our area would be responsible for assisting and requesting ambulance strike teams, and then also notifying those facilities outside the mutual aid region that they may be receiving patients. For events occurring outside the region, the RDMHC will coordinate with MOACs within the region to establish temporary field treatment sites, or FTSs, or patient reception areas as necessary, while working with the control facilities to rapidly assess receiving facility capabilities and coordinate patient distribution. So this is really a big incident that's going to be lasting for a while, that we may need to set up field treatment sites, and that's the transitioning from the triage and treatment areas of an MCI to a field treatment site, where they're going to be receiving more austere care, but it's not care that they are going to immediately need in a hospital. And we save the hospitals for the immediate or the more severely injured delayed patients. Notify the County Office of Emergency Services or OES coordinator to activate and support the field treatment sites, including establishment of an ICS structure, medical branch director, and accurate patient tracking. Notify the local control facility of the event, the need for patient distribution and tracking. Notify EMS providers to help support the field treatment sites, including any medical transportation needs. Monitor EM resource to ensure receiving facility capabilities are accurately reflected. Again, important, because if you're to the point where you've initiated a field treatment site, all of your local receiving facilities are most likely impacted and can't handle any more patient load. So as the patients are assessed and discharged or admitted into the hospital, and that frees up space in the emergency room, updating EM resource and the control facility would help us in getting patients out of the field treatment sites into better care in the emergency departments. Maintain communications with the RDMHC to facilitate patient movement and patient distribution. Ensure final patient tracking information is provided to the RDMHC for feedback. I haven't mentioned this before, but I've been kind of putting it in there about patient tracking. It is paramount that quality patient tracking begins at the scene, and that is continued through the control facility and receiving facilities. When you're dealing especially with a violent situation, active shooter, mass violence type of situation, or a school bus crash, that we begin tracking patients from the scene with not only triage tag numbers, but names, so that we can reunify the families with these patients at a later time. We don't know who the mom and dad are of tag number 1234, but we could definitely get John Smith's parents hooked up with him if we know the name, and that will be paramount in the patient transportation group supervisor, medical group supervisor at scene, communicating with the control facility later on after the incident, and making sure that all the tag numbers have names associated with them. That way, when we're trying to get the parents with their loved ones, that can be done in a more efficient manner. So responsibilities: regional disaster medical health coordinator specialists are responsible for the coordination of medical and health mutual aid among the operational areas within the mutual aid region. So if your event goes outside of your operational area or county, the RDMHS needs to be brought in to help coordinate activities outside of those political boundaries. So, are you ready for something like this? This probably isn't an MCI, even though it looks pretty wild. It was probably fairly low speed. The vehicle damages aren't there to support necessarily major trauma. There may be some injuries, but this may be something that is an MCI alert, but when the responders arrive at scene, may be downgraded or canceled altogether. I'm sure we all know about these pictures, and this was the Orland bus crash. What you see here is really good scene management. If you look at the patients that are being carried by or assisted by the firefighters there, the triage tags are on and appropriately marked for that category of patient. They're being moved away from the incident site, and minor injuries are being taken care of. And these are all the minor or walking wounded patients. So again, this happened in a rural response area. Patients were handled appropriately and quickly. The control facility was advised, and MCI Alert was established and confirmed. And the patients got taken care of. Another potential big MCI, this would be considered an MCI Alert for sure. I don't know if you can see, but underneath that first bus on the back end of the trailer, there's actually a car wound up in there. So if the buses were loaded, plus the car, plus the semi, would definitely prompt an MCI alert, and if there were multiple injuries, that would be confirmed. So in the back of the plan, there are some forms for the control facilities and receiving facilities. Strongly recommend you print those out and review them, put them in a binder. Again, MCIs are not day-to-day activities. Strongly encourage putting together a binder that no matter who's on, they know where that binder is, pull it out and can start referring to it to get the information they need to be successful during during an MCI. You should have a directory in there as well of important phone numbers like the control facility, as well as the control facility having the phone numbers to all of their receiving facilities within their control area. Backup communications. What happens if the trunk lines within your receiving facility or control facility go down? Do you have cellular backup, or do you have radio capabilities as well? You should have a regional map on the wall so you can pinpoint the incident location, and then from there figure out what the closest receiving facilities are going to be. Also in Appendix A, the receiving facility capacity worksheets, patient destination worksheets, and then the MCI critique forms for both receiving and control facilities. The directory for state authorities and receiving facilities, control facility assignments, backup communications, review the algorithm. What are you going to do and who are you going to notify if communications do go down? This is a map of the control facilities within Region 3. Starting at the bottom, Yuba Control handles Yuba and Sutter counties. Butte Control handles Glenn, Colusa, and Plumas counties. Shasta Control handles, obviously, Shasta, Siskiyou, Tehama, Trinity, Modoc, and parts of Lassen County. NorCal EMS is in contacts with Renown Hospital in Reno to take part of Lassen County, just to the large scope and rural nature of that county. So if you have any questions, please let us know. Here at NorCal. Also refer you to the Region 3 MCI Plan Manual 2 for control facilities. Hopefully that would be able to answer most of your questions. Again, communications is key. Make sure you keep that open line of communications between the control facility and receiving facilities and back. And for the control facilities, make sure you're training on communications with your field providers. Thank you very much and have a great day.